Good morning or good afternoon. Good morning or good afternoon, whoever's joining us today. My name is Dr. David Millett, and I'm speaking to you on the topic of the initial evaluation and management of epilepsy at the 2021 Disney Epilepsy EXPO and Patient Education Day. So I am about to share my PowerPoint presentation for you. I have a presentation for you here today. Let me figure this out. Here we go. And I'm going to maximize this a little bit here. There we go. Terrific. So I will be speaking for part of an hour on the initial evaluation and treatment of epilepsy. This talk is subtitled Why You Need to See an Epileptologist, and that subtitles I think is quite appropriate because many patients who come to see us and have been previously under the care of a community neurologist or general neurologist are often will tell us that there's so much that they now have learned about epilepsy and about their own diagnosis that they never knew before, both in terms of underlying cause as well as treatment options for them. So let's go. Hopefully I can get it to go. There we go. So I'm going to address a number of critical questions and issues in the next 45 minutes or so. I think the most important question that we always start with is, was whatever event it is actually a seizure? This is a talk on initial evaluation and management, and most often patients present to our clinics after their first lifetime seizure or first neurological event that is similar to a seizure or seizure-like event. And we always have to keep in mind, was it really a seizure? If it was a seizure, was it provoked or unprovoked? We'll talk about some particular issues, states, causes, medications that are often associated with provoked seizures and why it's important to identify potential triggers for seizures in patients without epilepsy who do not otherwise have a predisposition for epilepsy or seizures. Sort of along similar lines, was this really the first seizure? And I've taken care of many patients who came to see us for their first convulsion, fairly dramatic event, similar to the child or young man that you see in the lower right of Raphael's famous painting, The Transfiguration of Christ. Here with his right arm outstretched and elevated, the left arm similarly tonic extension, the eyes deviated. So they will often come to us after their first lifetime convulsion, but on closer questioning, it turns out that they've had undiagnosed epilepsy for quite some period of time. We're going to talk a little bit about the difference between focal and generalized seizures, the importance of diagnostic studies, and get into some of the details about MRI and EEG. We'll move on to then a discussion about epilepsy. Is it epilepsy? That's a question that many patients ask me over the course of either the first or the second clinic visit. Do I have epilepsy? And we'll talk a little bit about what that means anyway. We'll touch on comorbidities with specific attention to depression and anxiety, which occur in about 50% of patients with epilepsy. We'll talk a little bit about anti-seizure medications, choosing the right drug, and often choosing the right dose. I'll touch a little bit about syndromes, epilepsy syndromes, and prognosis, and we'll talk a little bit about what would have historically been referred to as special populations. I'm not going to be talking about children or pediatric patients in this session. I'll be really focusing on adults, and we really have to recognize two special populations: women, and particularly women of childbearing age, as well as the elderly, because they really merit special considerations when we're choosing anti-seizure medications and monitoring them. So we'll start with the first question. Was whatever event it is that patients had and brought them typically to the emergency room, or perhaps it was a nocturnal event, patient went back to sleep and awakened the next morning with having bit their tongue or bloodied their mouth, or a spouse or significant other saw some strange movements in the bed the night before. The first question that we always need to keep in mind is, was it a seizure? A seizure is defined as an abnormal period of electrical brain activity that results in an alteration of movement, that is to say some motor phenomenon, sensation, behavior, or thought. And the different parts of the brain where the seizure begins often will correlate with one or more of those physical manifestations of a seizure. But this is a widely understood definition of seizure. And most of the time, if we were to have a patient who is hooked up on EEG or brainwave test electroencephalogram during one of their seizures, we would be able to detect some abnormality in brainwave activity at that time. The seizures or seizure-like events that patients come to the clinic for consultation regarding typically fall into one of two categories. They are most often the convulsion or grand mal seizure that will typically bring a patient to an emergency room. Somebody will witness a seizure, a family member, loved one, coworker, and contact paramedics, and they're brought to an emergency room. So this is most commonly referred to as a tonic-clonic or generalized tonic-clonic seizure, but there are essentially two other important entities or diagnoses to keep in mind when thinking about potential alternatives. One is an entity called convulsive syncope, and although convulsion or convulsive appears in the name of this condition, it's not an underlying epilepsy or epileptic condition or seizure disorder. Convulsive syncope is a sort of reactive, a reaction of the brain, sometimes like a seizure, sometimes is a seizure, but it's always in reaction to an episode of what's called syncope. Syncope refers to a fall or collapse, typically related to the brain not getting enough blood supply. There are a variety of different reasons for syncope, but essentially, if the brain is deprived of adequate oxygen for a short period of time, it essentially shuts down, and patients will collapse. And shortly after they collapse to the floor, they can go into a short period of time in which their body either twitches, stiffens, or they may actually have a full tonic-clonic seizure. But it's always triggered by an episode of syncope. So these are not unprovoked seizures. These are provoked events. The other entity that is important to keep in mind are what are referred to as psychogenic non-epileptic seizures, PNES. Sometimes they're abbreviated just as NES or non-epileptic seizures. These have previously been referred to as pseudo-seizures or psychoseizures. We tend to we tend to not use those terms anymore. But there are often seizure-like behaviors, sometimes twitching, stiffening, jerking, unresponsiveness, and they can be related to anxiety, depression, post-traumatic stress disorder, and in rare cases, patients who have more severe psychiatric problems or have some kind of primary gain from being connected to healthcare and the hospital. On the other hand, there's another type of event that patients will come to see us for, and these are non-convulsive seizures. Sometimes they're referred to as absence seizures or complex partial seizures. That's some older terminology, but they're currently referred to if this is an epileptic event, as a focal impaired awareness seizure or focal unaware seizure. But there are a number of things that can mimic or simulate a non-convulsive or focal impaired awareness seizure. One is the non-epileptic events that I mentioned previously, but another is something closely related to strokes called transient ischemic attacks, when an area of the brain doesn't get adequate blood supply for a short period of time and can develop stroke-like symptoms that can also be quite similar to seizures. Probably the most commonly seen of these is a brief, what we call speech arrest, or inability to speak for a few moments or minutes. But there are a number of other potential causes of neurological dysfunction that can look like a seizure. One is a medication effect or toxicity. Second would be some kind of a sleep-related movement disorder, chronic sleep deprivation, and cerebral hypoxia, that is the brain chronically being deprived of oxygen, for example, in patients with obstructive sleep apnea. So all of these conditions can lead to a period of time where a patient's confused, disoriented, perhaps not responding to family members or friends or coworkers for a short period of time, and end up seeking neurological attention. So it's really important to keep some of these other things in mind when making the diagnosis of initial seizure and possibly the diagnosis of epilepsy. Let's try to advance this. There we go. The next really important question, once we've determined that the event was actually an epileptic seizure, is trying to figure out whether or not this was what we call a provoked seizure or an unprovoked seizure. And so you might ask the question, well, why does it matter? Seizure is a seizure. It's true, but the management or intervention that we would follow up on for those two different conditions are quite different. And the diagnosis of epilepsy, which is sort of what we're getting to, we'll be getting to towards the end of this talk, is really based on at least one unprovoked seizure. So it's really important to figure out whether, even if a patient had a seizure, whether it was provoked or not. So if the seizures are provoked, and we'll talk about what the common triggers are in a moment, you can see some of them listed here on this page and some of the pictures that illustrate them. If a seizure is provoked, then the intervention, the medical intervention, is essentially to eliminate that trigger, that provocative factor that led to the seizure, oftentimes requiring some kind of lifestyle modification, depending again on whether this was withdrawal from benzodiazepines such as Xanax, which you see here in the upper left-hand panel, or chronic sleep deprivation, chronic insomnia. It's basically identifying and addressing whatever that factor or factors were that contributed to the seizure. So common triggers, I've listed them here. medications play two roles in potentially triggering seizures, provoked seizures. In the first case, there's a group of medications, typically benzodiazepines, but also some of the older anticonvulsant medications such as phenobarbital, as well as alcohol. They bind to a receptor in the brain called the GABA receptor. GABA is a potent inhibitor of brain activity, and as long as the benzodiazepine, the Xanax, or the alcohol, or the clonazepam, the Klonopin, is binding to those receptors, it's exerting some inhibitory effect on brain function. When you stop those medications, or you stop drinking after doing it for a consistently for a period of time, all of a sudden those inhibitory circuits are released from their inhibition, and you get excessive excitation of the brain, which often will translate into a seizure. So withdrawal from alcohol, benzodiazepines is probably the most common trigger that we see in clinical practice. And oftentimes it's patients who can be using either medication for a recreational standpoint, or prescription medications such as alprazolam or Xanax. That's probably the most commonly implicated one, because it's such a short-acting medication, and withdrawal becomes very problematic from it. Medications can play another role in that some medications will lower what we refer to as the seizure threshold. Every organism with a brain has some threshold for having a seizure. If you apply enough medications, or enough sleep deprivation, or change their metabolites or their electrolytes, any organism with a brain can actually have a seizure, and every human has their own seizure threshold. There are some well-known medications that are known to lower the seizure threshold for some individuals. Probably the most commonly encountered one in clinical practice is Wellbutrin, but also some antibiotics, quinolones, and particularly levofloxacin and ciprofloxacin, as well as theophylline, have been in widespread medical use, perhaps declining to some degree now, but still seen enough to be implicated in causing seizures. We have drugs of abuse. Cocaine can directly trigger seizures, and even some of the less well-known drugs of abuse. I had one patient who came in with what appeared to be a full panoply of seizure types, myoclonic seizures, impaired awareness seizures, and convulsions that were all associated with excessive use of a Southeast Asian stimulant called kratom, which that individual was extreme sleep deprivation, flashing or flickering lights, and some patients that are particularly sensitive to those, and as I mentioned before, metabolic or electrolyte disturbances can often cause a seizure. Alternatively, once we've figured out whether this was a provoked seizure or an unprovoked seizure, the next question then often becomes, was this really the first seizure? As I mentioned at the outset, oftentimes patients will present to a neurologist for evaluation of their first convulsion. They've been brought to an emergency room. They've been told they've had a seizure. You need to follow up with the neurologist, and they may not have recognized that episodes, for example, of myoclonus, that's brief jerking movements of the hand or limbs, or limbic symptoms, as I've listed before. These are referred to as limbic symptoms because they're all related to the limbic circuitry of the brain. That's often involved in temporal lobe seizures. We'll talk a little bit about more about that later. But limbic symptoms such as episodes of fear, panic, or anticipation, intense, overwhelming feelings, often of deja vu, an epigastric sensation, often like butterflies in the stomach, or as if you're in an elevator or a roller coaster, dropping or falling. Strange taste, oftentimes metallic, or smell, oftentimes an unpleasant burning smell or smell of excrement. Feelings of being in a dream or out of one's body, mild confusion or disorientation. I've had patients who came to me for their first lifetime convulsion, and then once we get into asking some of these about some of these more subtle, subjective kinds of feelings, it became clear that for the past many years, maybe once a month or every other month, they would have 2 or 3 minutes where they would experience these symptoms of fear or anticipation that something was going to happen, with some deja vu, feeling sort of dreamlike or out of body. And it becomes clear that although they're coming to us for their first convulsive seizures, their first disabling seizures, they've had these non-disabling seizures, which are really what these auras are, that have gone on for many years leading up to this. The next question that we try to get a handle on as best we can, and oftentimes we are not able to come up with it to answer this question on the initial consultation, but rather on follow-up after we've had some diagnostic testing, is whether the seizure and the epilepsy is focal or generalized. Why is that important? Well, it's important for a number of reasons. It's important for prognosis. How long is this epilepsy going to last? Is there a chance that a patient might outgrow it? Is there a chance that other family members may also suffer from it? Is there a chance? What is the chance or the rate of seizure control with medications? Are there other options available for treatment of seizures if medications don't work? So it does really become important early on in the management of epilepsy to understand whether seizures are generalized or focal. Most oftentimes, generalized epilepsies will present in early life, childhood, oftentimes, between the ages of 5 and 12 or 13. But juvenile myoclonic epilepsy, which is a form of generalized epilepsy, will frequently present with the first seizure in the late teens or early 20s. And I have occasionally seen patients even in their 20s or 30s with their first lifetime seizure who has an abnormal EEG supportive of generalized epilepsy. So what are the differences between the two? Generalized seizures and generalized epilepsy involve seizures that involve both sides of the brain, both cerebral hemispheres at onset. There are generally 3 different types: absence or brief staring seizures, myoclonic seizures or brief jerks, and then the generalized tonic-clonic or grand mal seizures. They often occur without aura or warning. For the absence seizures, there's oftentimes no physical manifestation. There's just staring for about 10 seconds to 12 or 13 seconds, sometimes with some eye fluttering, but that's about it. As I mentioned, they affect both cerebral hemispheres. EEG abnormalities are very common in generalized epilepsies, particularly during sleep. And they're often bilateral. They may shift a little bit between the right and left sides, but we definitely see them involving both sides of the brain. MRI is often normal, and one of the reasons, as I mentioned, it's important to understand whether you're dealing with a generalized epilepsy is because there's a more limited number of seizure medications, anti-seizure medications that are effective for generalized epilepsies compared to the focal epilepsies. So there are some medications to avoid, and there's some counseling to give patients, especially in terms of avoiding alcohol, sleep deprivation, et cetera, for the generalized epilepsies, because they do tend to be more sensitive to those triggers. Focal epilepsies, on the other hand, begin in one lobe, or usually a part of one lobe of the brain, and then can often spread to involve the rest of the lobe or other lobes, or in fact both hemispheres. They're often preceded by an aura. We talked about some of the auras before, and the auras or warning signs the patients will experience before a focal seizure will depend on where in the brain that seizure is starting. So, for example, temporal lobe seizures are associated with oftentimes this feeling of anticipation that something's about to happen, deja vu, the metallic taste, et cetera. Frontal lobe seizures are often can be preceded by some changes to speech or language, some difficulty concentrating or thinking, or even repetitive thoughts. The motor manifestations can be hyperkinetic, some bicycling, or very vigorous motor phenomenon before the convulsion, or they can just simply begin with some jerking movement, typically involving the right or the left side of the body, or some pulling movements, or tonic motor activity, often involving the face or the upper extremity. They will often progress, particularly in the initial event, the initial seizure. If a patient's not on antiseizure medication to slow the progression of the seizure, they will often progress quite rapidly to a generalized tonic-clonic seizure with loss of consciousness. Oftentimes the EEG is abnormal, but so is the MRI. So we will often find evidence of an old scar, some kind of brain injury, gliosis is the technical term for that. We might find a brain malformation, a prior stroke or infarct, or even a tumor, whether that's a benign tumor or a malignant tumor. We may find one when we look carefully at the area of the brain that's been implicated in initiating the seizure. With the focal seizures, there's a much larger choice of anti-seizure medications that are indicated. So that's why it's really important to understand the type of seizure, the type of epilepsy we're dealing with. I'll spend a few minutes talking a little bit about diagnostic studies. This talk is really limited to initial evaluation and management or treatment of epilepsy. And so I'm going to only talk about MRI and EEG. There are many other forms of brain imaging, and there's also more additional forms of inpatient monitoring, EEG monitoring, and monitoring of seizure activity from inside the head, directly from the brain. I'm not going to discuss those today. I'm just going to talk about initial evaluation. So it's really important to have a high quality epilepsy protocol MRI. In every epilepsy center in the country now, standard of care is really a 3 Tesla MRI. Rarely I've seen a 1.5 Tesla study that is adequate, that gives us about as good signal to noise ratio as a 3 Tesla machine. But most of the time, we want to really get a 3T study. Technique is critical. It's really essential to scan the entire brain from the frontal pole all the way to the occipital pole in thin coronal slices, which you see here in the upper 2 panels, and with multiple sequences. So a T1 sequence, which highlights the structural anatomy, T2, which highlights the difference between the gray and the white junction, which we see here in these top two panels. These are both coronal sequences like this with a T2 sequence, and then flare, which is particularly sensitive to subtle variations in the water content and cellular and essentially scar formation in the brain, and can oftentimes identify a very subtle area of scar formation that isn't apparent on some other sequences. The interpretation, not just the MRI, not just the images, but the radiologist who's reading that study is as important as the technical aspects and the hardware of the machine itself. MRIs for epilepsy are optimally read, performed, and interpreted in an epilepsy center by a radiologist who's really dedicated to, has trained and dedicated to in reading MRIs. And as a cautionary tale, I've had many patients who've come back to see me, and they've read through in their electronic medical chart, or they've been told that their MRI is normal, and they come away thinking, well, I don't have epilepsy, it wasn't really a seizure. A negative or a normal MRI does not, unfortunately, exclude the diagnosis of epilepsy. So we really sometimes have to move on to other types of imaging to make sure. I've just illustrated the role of the importance of high-level imaging at an epilepsy center. Here, these are 3 images of 3 different patients who all had MRIs performed someplace else in the community or at another hospital that were read as normal, were not started on anti-seizure medications, or not offered surgery or some kind of further diagnostic workup, who, when we rescanned them with an epilepsy protocol study and carefully looked at that MRI, we were able to identify the culprit, basically the abnormality or malformation of the brain giving rise to the seizure. So, for example, this is a frontal lobe, left frontal polymicrogyria in this young woman. This patient who presented with first lifetime seizure, but had these auras going back many years, turns out to have these areas of gray matter neurons that here, just lateral to the ventricles here and here. She actually had them lining both ventricles going all the way back. This is a syndrome known as polyventricular nodular heterotopias. And this patient has right temporal lobe epilepsy with sclerosis, or which you can identify with as increased brightness on the hippocampus here on the right compared to the left, which is normal. So these were all read as normal by an outside imaging service and radiologists, which are clearly not normal, and gave us the answer to the question of where their focal seizure is coming from. Shorter discussion on EEG. I'll be quite straightforward with regards to the initial diagnosis and management. More is usually better. So a routine EEG that patients might have in a doctor's office or at the bedside when they've been admitted to an emergency room or to a hospital for their first lifetime seizure. That's typically a 20-minute EEG. It's really inadequate for the diagnosis of epilepsy. In my own practice, and most of the folks that I know who do epilepsy full time, we usually begin with a 45-minute, sometimes a 60-minute EEG, oftentimes sleep deprived, to make sure that we capture some sleep during that period of time. And if that study is negative or normal, and I really need to know, am I starting medications? Is this epilepsy or a provoked seizure, we'll move on to oftentimes a 48-hour in-home ambulatory video EEG study to make sure that there either are epileptic discharges supporting the diagnosis of epilepsy or there are not. This is an older paper, but just really illustrates the point with regards to imaging, and you don't need to be a professional to understand that the numbers here. So this is a study that was published back in 2002. A standard MRI read by a non-expert radiologist in the community had about a 39% sensitivity to finding the abnormality that caused the seizures. Whereas if you used a dedicated epilepsy protocol MRI with an expert assessment of the scan, that sensitivity goes up to 92%. So a huge difference in the quality of neuroimaging in the community versus an epilepsy center. So let's move on in the last 20 minutes or so to the question of epilepsy, comorbidities, and medical management. So the next question that comes up once a patient presents with their first lifetime seizure, we get an EEG, we get an MRI, sometimes we get some hint that they might have had some seizures in the past. The next question is this epilepsy? Do I have epilepsy, doc? And what is epilepsy anyway? So epilepsy is a well-established, has a well-established and agreed upon definition. It's a disorder of the brain characterized by a predisposition to generate or produce seizures. Practically, this comes down to essentially one of two conditions: either a lifetime history of 2 or more unprovoked seizures greater than 24 hours apart. We don't count a cluster. And again, these are unprovoked seizures, so we don't count febrile seizures as a child. We don't count alcohol or benzodiazepine withdrawal seizures. And they have to be true spontaneous or unprovoked seizures. On the other hand, you can also essentially get the diagnosis or achieve the diagnosis with one seizure and a greater than 60% chance, sorry for the type of chance, of a second seizure in the next 10 years. Following the first seizure without any other information, there have been many studies looking at how many patients will go on to have a second seizure in X years, 1 year, 2 years, 5 years. So the risk of a second seizure in the next 2 years without any additional information varies somewhere between 21 and 45%. These are for adults who present with their first lifetime seizure. But in general, any of those 4 conditions that you see below will double that risk. And doubling that risk, if you just figure with an average of about 30, 32%, doubling that risk increases the chances to about 60 or greater than 60% of having a second seizure within 2 years. So prior history of brain injury, any abnormality on neuroimaging, which could be CT or MRI, any epileptiform abnormalities on EEG, and or a nocturnal seizure, a seizure that arises from sleep as opposed to an awake seizure. Any one of those 4 conditions will double the risk of having a second seizure at somewhere between 1 and 4 years. So, this definitely places any of those individuals at a significantly higher chance of having a second seizure in 10 years, and arguably will make the diagnosis of epilepsy. So, as I often will tell my patients, epilepsy is a spectrum disorder. I have patients who've had a single lifetime seizure, got started on medications, and have never had another one. And then I have patients who have seizures almost every day or every day on multiple medications, very challenging situation. 2 ends of a very broad spectrum, and it's important to keep that in mind. I'll touch on what we call comorbidities because they're often missed, but really important to pick up on in the first consultation with an epilepsy specialist or epileptologist, because they will. They're number one, they're oftentimes part of the epilepsy. Number two, they're oftentimes not recognized and not treated, and they contribute significantly to quality of life. So to begin with, depression and anxiety or mood disorders are the most common psychiatric diagnoses in epilepsy. They affect nearly half of all patients with epilepsy or persons with epilepsy. 3/4 of those with depression also would meet criteria for an anxiety disorder. So this is very, very common. Why is it common? It's common because, as I mentioned a few moments ago, the dysregulation of mood is part of the epilepsy. Epilepsy in adults often involves abnormal levels of neurotransmitters such as dopamine and norepinephrine that we know are involved in regulating mood. The most important system in the brain that's involved in seizures in adults is the temporal lobe and the limbic system. And that system also underlies the regulation of our emotional states and our emotional and psychological reaction to the world. So we can see both structural changes, oftentimes scarring, atrophy of the systems that are involved in regulating our emotions, as well as functional changes. If we, for example, obtain an FDG PET scan of the brain, we'll see changes in the metabolic activity of that system. There's also oftentimes abnormal endocrine function in patients with epilepsy, and this is also related sometimes to changes in mood. The second comorbidity that's rather common in epilepsy is migraine. It's pretty common overlap, maybe about 20–25% of persons with epilepsy will also have migraine. Sometimes it will be difficult to distinguish the two, especially in a patient that's never had a convulsive seizure or convulsion. They've just had more minor seizures or neurological symptoms, and we're trying to tease apart, is this migraine, is this epilepsy? Because patients will often have a migraine after seizure, and sometimes I've seen patients that have some strange neurological symptoms. They have very frequent headaches, and then once we get some testing, it becomes clear that what they're really having is they're having very subtle seizures, and the postictal or the postictal migraine or headache afterwards. So it is really important to tease these things apart. Some of the anti-seizure medications also are quite effective at minimizing migraine as well. So it's important to maybe pick the right medication for comorbidity. And I think I'm going to get to that in the next 2 slides. I'm going to finish the talk in the last 10 minutes or so with a brief discussion on anti-seizure medications. This is not meant to be exhaustive. It's really meant to touch on sort of what goes through our heads in terms of selecting anti-seizure medications at that initial consultation or follow-up consultation when we decide it's important to start a medication at this point in time. So let's go. Some early considerations or some general considerations. We know now, based on a series of large clinical studies, that early treatment, initiation of anti-seizure medications after the first seizure reduces the second seizure within the next 2 years by an absolute amount of 35%. So somewhere between 40 and 65, 66% of patients with their first lifetime seizure will have a second seizure at 2 years. If we initiate treatment the range drops on average by about 35% to, as you can see here in a variety of about 8 or 10 published studies with a broad range, but there's about a 35% absolute risk reduction for a second seizure if we start anti-seizure medications. This reduction in the risk of future seizures is particularly important for patients who wish to have their driving privileges reinstated, return to supervised sports, including supervised water sports, or independent living as soon as possible. Sometimes they're taking care of children at home, minors, or they want to return to work. They need clearance, in particular for driving, school, and sports, and it's more timely to clear patients to resume driving and their other activities of daily living if they're on an anti-seizure medication versus not. We oftentimes have to wait a longer period of time in my own practice, 3 months minimum off medications before returning to driving or supervised water sports, for example, whereas that's usually a shorter period of time if patients are on anti-seizure medications. A note about adverse side effects. They vary widely, but they're generally mild. They're oftentimes self-limited, occurring really only in the first few days or the week of starting a medication or adjusting the dose of a medication. And they're oftentimes reversible with modification of the dose, converting patients from an immediate release to an extended release form of the medication, or just switching to a different anti-seizure medication. And we oftentimes have to do that if patients aren't tolerating their initial medication. Some of the side effects are actually beneficial, and I'll touch on that in the next slide. I mentioned that, for example, depression, anxiety, migraine are the most common comorbidities in epilepsy, and we can often kill two birds with one stone by choosing the right anti-seizure medication for a given patient, because we'll be able to treat both their mood disorder and their migraine, or possibly help them manage their obesity with the appropriate choice in anti-seizure medication. And then finally, and this is perhaps beyond the initial consultation, but sometimes patients do ask, "Hey doc, what are the chances that I'm going to have another seizure even if I take this medication?" So about 1/2 of patients will remain seizure-free for at least a year with the first anti-seizure medication that we choose, and over time, about 2/3 of all patients will be adequately controlled with further trials of anti-seizure medication if the first one doesn't work. So I'm going to just touch on now in the last couple of slides on some of the anti-seizure medications that we oftentimes initiate in clinic, or actually what happens more often, patients have already been started on medications when they come to see us for their first lifetime seizure, either in the emergency room or in the hospital. So perhaps almost everybody who might be watching this has heard of Keppra or levetiracetam. I've listed what I would consider to be the top 6 choices of initial anti-seizure medication, and some notes and comments, things to keep in mind about them. Levetiracetam, or Keppra, is far and away the most commonly used anti-seizure medication for the initial management of seizures in adolescents and adults. And with good reason. It is effective, it's very safe, it's available in oral, both tablet as well as suspension, and an IV formulation. It's what we call broad spectrum, so it's good for both focal and generalized epilepsies. In its in its original formulation of Keppra or levetiracetam. It's typically dosed twice a day, and it has no organ toxicity, no drug-drug interactions. So it's a very, very safe and very effective anti-seizure medication. It is associated with a significant adverse side effect of generally affecting mood. Anxiety, irritability, or insomnia can affect about a third of patients. Smaller number can become very sedated with the medication. Maybe 1 in 10 or 1 in 20 may have sedation that forces us to pick a different medication. But what I've found is that oftentimes converting patients to an extended release or XR formulation, supplementing the Keppra with a vitamin B2, or adjusting their dose often improves side effects. I'll just touch on the others. So Zonegran or zonisamide is probably one of my favorite anti-seizure medications, largely because it has a very long half-life, about 50 to 60 hours. So that allows it to be dosed once a day. It's oftentimes well tolerated. It's a broad spectrum medication, so it's good for, again, for both focal and generalized epilepsies. I've had, I would say, more than half of patients who start zonisamide, in my experience, tell me that they don't have any significant side effects to it, but the ones that do often may develop a rash, sedation, some dizziness, and may again have to adjust the medication, pick a different drug. Trileptal or oxcarbazepine came out in the 1990s. It's been around for quite a long time. It's a well-tolerated, twice-day dosed, effective medication related to Tegretol. It was a designer drug that was designed to avoid the side effects of Tegretol or carbamazepine. We oftentimes are converting patients from Tegretol to Trileptal to avoid some of the side effects of the older medication. It can be mood stabilizing. I've listed some of the side effects here. It is available in an XR formulation, which is very handy and improves compliance. One of the other medications, perhaps the most important medication to consider for patients that do have major depression or tend towards a dysthymia, mild depression, or bipolar disorder is Lamictal. So Lamictal is a very potent mood stabilizer, an excellent antidepressant. The one drawback of Lamictal is it is associated in a small number of patients, maybe 10 or 20%, with a rash or an inflammatory condition known as DRESS. And for that, in order to avoid that, we have to start at a low dose and gradually build up over about 4 to 6 weeks. It does often requires dose adjustment in pregnancy, and there are some drug-drug interactions, including with oral contraceptive medications, which will lower the amount of Lamictal in the system, because it will increase the liver's ability to break it down. So you do have to pay attention to other medications and check levels of Lamictal more frequently. Topiramate is a very effective broad-spectrum anti-seizure medication, also good for migraine prevention. It does have some cognitive dysfunction associated with it and some numbness and tingling or paresthesias. It can also be related or can cause some appetite suppression and some mild weight loss in about a third of patients, so something to keep in mind. And finally, Vimpat or lacosamide, still brand name, but soon to come off brand and probably available generic next year. Maybe broad spectrum. I have seen it use it in some patients with generalized epilepsy, mostly with focal epilepsies, though. Generally well tolerated, no significant drug-drug interactions or organ toxicities. I would say these are probably my top 6. And then beyond initial treatment, I've listed a number of other older and newer medications here that are useful as add-on or conversion if we exhaust several of the other the initial medications I mentioned. So Depakote, the older drug, it's been around since the 1970s. It's especially useful in elderly males because the males are not likely to become pregnant, and older males tend to not experience some of the cosmetic side effects that Depakote can have in young women. Onfi or clobazam is particularly effective in difficult to manage generalized epilepsies. Aptium or eslicarbazepine related to trileptal, newer version of it that has better penetration into the central nervous system, effective for patients with focal epilepsy, not broad spectrum. Probably the newest medication available widely, Xcopri or cenobamate, has been studied in patients with severe epilepsy, has a very remarkably effective in terms of reducing seizures in patients with severe epilepsy. So definitely something to consider for patients that have not done well on their initial 2, 3, or 4 medications. There's really, at this point in time, a limited role for the older anti-seizure medications, such as phenytoin, carbamazepine, or phenobarbital. They're dirty drugs. They have, oftentimes will have narrow therapeutic windows with side effects, lots of drug-drug interactions. They have effects on bone mineral density. They can have other long-term side effects like neuropathy. They can reduce the effectiveness of other medications. We generally avoid them if we can. I do sometimes in the initial consultation talk about potential role for dietary therapy, such as the keto or modified Atkins diet, which can be very effective along with medications in reducing seizures. And in young women, I always make a point of talking about folic acid supplementation for maximizing reproductive health. All of these anti-seizure medications have a small risk of birth defects associated with them. The newer medications that were that I've listed here as generally first choice medications for managing seizures and epilepsy have less than a 3% risk of birth defects associated with them, which can be further reduced in supplementing with folic acid. So very important for young women who present with for initial seizure and possibly diagnosis of epilepsy, and will be on anti-seizure medications long-term to optimize their reproductive health. So that's about it for the initial diagnosis and management of epilepsy. If you have any questions, you'll be able to, I think, submit them to our moderator, Sheena Dimon, who's also our Hoag Epilepsy Program Nurse Navigator. She can forward them to me, and I'm happy to address them if I can, or we'll refer you to somebody who can. Thanks for paying attention. I hope you all learned something, and take care. Bye-bye.